Welcome to Orthopedic Grand Rounds. Today our topic is massive rotator cuff tears. Specifically, the title is Brought to Your Knees by the Rotator Cuff, Solution to Massive Cuff Tears. And our chief resident, Derek Rains, who has a particular interest in this topic and is going to be pursuing a sports medicine fellowship, has put this talk together, and his assistants today are two faculty members, Chris Wall, who is an assistant professor in our department and specializes in sports medicine and has a particular interest in arthroscopic reconstruction of rotator cuff tears, and Kevin Smith, who is a clinical associate professor in our department and had done his shoulder fellowship quite some time ago with Dr. Mattson. And he is going to take the position of advocating for open rotator cuff repair. So Derek Rains is going to start us off.
Thank you, Dr. Chansky. I'd like to tackle today one of the more challenging areas of shoulder surgery, and that's the treatment and really management of massive rotator cuff tears. We have with us today an expert panel, Dr. Smith, clinical associate professor from Northwest Hospital, and Dr. Wall, assistant professor and team physician from the University of Washington, who will help us go through some cases later and get a better understanding of what treatment options are available for these sort of tears. I'd like to spend the first part of the morning going through kind of the natural history of what is a massive rotator cuff tear, and I think really challenge the concept that massive rotator cuff tears have a poor prognosis. We'll review what treatment options are available for these sort of injuries. We'll spend the latter half of the morning going through some cases and hopefully stimulating some debate and really looking closely at some of the more controversial aspects in caring for these injuries. As Dr. Chansky mentioned, we're also debuting our audience response system, so we're going to do some fancy computer work here and swap screens over here, and we'll move forward with the first question just to kind of pull the audience on your thoughts on massive tears. So you can use your clickers at any time now. What is a massive tear? Is a massive tear an irreparable tear? Is it a tear with a size greater than 5 centimeters in its greatest diameter? Is it a tear that involves detachment of at least 2 entire tendons? A tear area size greater than 2 by 2 centimeters? Or any combination of the above? So I think that this is a very interesting response, and I think we're going to talk about this a little bit more in detail. And I'd like to challenge those that answered all of the above that massive tears are not necessarily irreparable tears. And I'd like to show you some options of how these can be treated. Next question, for those of you that treat rotator cuff tears, do you approach these from an open approach, arthroscopic approach, or a combination of both? Kind of across the board. And finally, a bit of a historical review on rotator cuff repairs. Who performed the first surgical repair of the rotator cuff? Good. So as most of you answered, the first surgical repair of the rotator cuff was credited to Codman in 1909. The first published report and description of rotator cuff tears in the literature was by J.G. Smith in the London Medical Gazette in 1834. And an interesting quote from Dr. McLaughlin in 1962 at the end of his career, after he had been treating rotator cuff tears for a number of years, was quoted as saying, "The wise surgeon, realizing that he may find little but rotten cloth to sew, will operate only by necessity and make a careful, guarded prognosis." And this really isn't that many years ago. And since that time, our understanding of rotator cuff disease and really the natural history of rotator cuff disease has been somewhat limited. It wasn't until the mid-90s that Schur did the first prospective study looking very specifically at asymptomatic rotator cuff tears, finding a 34% incidence in the general population. Milgram in the same year expanded on this concept and really showed the age correlation to cuff tears. So as we all age, the incidence of rotator cuff tears increases significantly. He also showed a small correlation with hand dominance as well. Yamaguchi in 2006 expanded on this concept and was the first to describe asymptomatic rotator cuffs correlated with contralateral shoulder pathology. So he looked at patients that presented with shoulder pain and were identified to have a symptomatic rotator cuff tear. Their incidence of an asymptomatic tear on the contralateral side was significantly elevated. And in these patients that had tears on both sides, the symptomatic tear was significantly larger. Tashan in 2009 raised the question of a genetic predisposition. So yes, Dr. Wagner, there is probably a genetic role to rotator cuff disease. That role is not a direct relation. If you look at the genetic distance, numbers 6 and 8 at the bottom of the slide, really second and third cousins. But it speaks a little bit to our understanding of where these tears come from and who may be more likely to have a tear as opposed to someone else. So who cares? There's a lot of patients with asymptomatic tears. As we know, it is difficult to make an asymptomatic patient better. But I think the important question to ask is what happens to these patients over time? And Yamaguchi answered this question well in 2001, showing following serial ultrasound exams on patients with asymptomatic tears, 40% of these tears got bigger over time, and 80% of those tears became symptomatic, ultimately requiring some form of treatment. And so I think what this speaks to, and what I hope you guys can take home today, that rotator cuff disease is really a spectrum of disease. There's from partial tears to full thickness tears, small tears, and eventually to massive tears. And potentially some of these asymptomatic tears start off as a smaller tear, progress over time, and result in a massive rotator cuff tear. So what is a massive rotator cuff tear? Well, there's a lot of definitions in the literature. DiGorio and Caulfield, one of the more quoted classification systems for rotator cuff tears, defines a massive tear as a tear greater than 5 centimeters in the greatest diameter of the tear. Harriman in 1991 described rotator tears based on the amount of tendon detached from the tuberosity. Gerber expanded on that in 2000 and said, well, a massive tear is a tear that involves detachment of at least 2 tendons. Just in May of just this year, Burkhart described a geometric classification for rotator cuff tears, which I think bears some interest, where he really relates diagnosis of the tear with preoperative MRI, relates that to treatment and the prognosis for patients, and really defining massive tears as a long and wide tear greater than 2 by 2 centimeters in area. So again, what is a massive tear? Well, it depends on who you ask. It's a tear greater than 5 centimeters in its largest diameter. Its area greater than 2 by 2 centimeters, involves detachment of at least 2 tendons. Commonly, these come in 2 different varieties. Most commonly is the posterior superior tear, tears of the supra and infraspinatus tendons, and uncommonly, tears of the supraspinatus tendons and the subscapularis. These are often chronic tears or acute on chronic tears, again going back to this spectrum of rotator cuff disease. That these most likely are tears that began in an asymptomatic patient that progressed over time. So many people, when you ask them about massive tears, will say, well, those patients have a poor prognosis. And there are many of the studies that they quote. Harriman and Gazzilli, 1991 and 1994, looked at repair of massive tears and found significant rates of recurrent defects following repair, even as high as 89% in 3 tendon tears. Very interesting study by Gallitz in 2004 looked at a series of 18 massive cuff tears treated arthroscopically, and 17 of those tears failed, 94% re-tear rate. Hujisman's in 2007, 264 arthroscopic rotator cuff tears, 53% re-tear rate for massive tears. So clearly that's some discouraging evidence. We know from many of these same studies that if you're able to get a massive tear to heal, patients do well. Harriman and Gazzilli, improved strength and range of motion. Functional results are directly related to the anatomic condition of the repaired cuff. And again, Gerber and Hujisman, same concept. Functional results are better with a healed cuff. But I'd like to challenge you to take a step back and think about who we're treating. We're treating patients. Patients often present with pain and functional impairment. We're not necessarily treating for a goal of an ultrasound intact cuff or an intact cuff on MRI. And if you go through the literature, I think that you can begin to understand that massive tears may actually have a better prognosis. In many of these patients that were found to have recurrent tears, many still display excellent shoulder function. Bigliani and Jose, 1992 and 2000, looked at a series of failed rotator cuff tears, all done open. 81% of those patients had satisfactory relief of pain. Jose described significant decreases in pain and improvement in function. And I think one of the more interesting studies, if you look at Gallett's study again, so this is a study that had 17 of 18 failures of arthroscopic repairs of massive rotator cuff tears. 72% of those patients had good shoulder and elbow scores at 1 year. Cho in 2009 did a prospective study looking at 169 patients followed for 2 years following arthroscopic repair, finding no significant differences between patients that had an intact repair by ultrasound or patients that developed a recurrent tear. Some of the more current literature looking at the arthroscopic repair of massive rotator cuff tears has shown excellent outcomes. Bennett in 2003, 95% satisfaction rate. Savoy in 2003, 88% good to excellent results. 98% of patients are satisfied. A very interesting study by Burkhardt in 2007 where he took some of the worst actors. These are patients, or all the patients he operated on, stage 3 and 4 Goutier fatty degeneration of the rotator cuff muscle bellies, showing 86.4 clinical improvement. He did classify these showing limited benefit in patients with stage 4 fatty degeneration. So again, a massive tear is not necessarily an irreparable tear. Clearly, tear size has some role in patient prognosis. But I think in reviewing the literature, there's a variety of other factors that play a role. And I think this is really more of a multifactorial decision when you sit down with patients and are thinking about whether the rotator cuff tear they have is truly an irreparable tear. These include things that we briefly discussed. Goutier fatty degeneration of the rotator cuff muscle belly, stage 3 or 4. Evidence of early arthritis, decreased passive range of motion, weakness, age, tear size, diabetes, and tobacco use. So what treatment options do we have available for treating the massive rotator cuff tear? Well, non-operative treatment options is one area to look at. Etoy in 1992 looked at patients treated with a multimodality program. So this includes physical therapy as well as corticosteroid injections. Found satisfactory results that deteriorated over time. Again, the concept of this spectrum of disease. So a tear that's not repaired probably at some point continues to get worse and progress. Ainsworth in 2007 did a systematic review of the literature and really found a poor data pool. So in looking at non-operative treatment options, we really don't understand very well if this is an effective treatment strategy for patients. Very interesting study in 2008, very small number of patients that had massive rotator cuff tears that were medically unfit for surgery were entered into a program, a physical therapy program, directed specifically at anterior deltoid re-education, and they had some very surprising results, which I think is encouraging in looking at physical therapy options for patients with massive tears. So what about corticosteroid injections? Keister in 2007 did a systematic review of the literature in the Yellow Journal showing little reproducible evidence to support routine use, looking at both pain and range of motion as clinical outcomes. So what about fixing these massive tears? So as we alluded to earlier, they can be fixed arthroscopically or open. Some of the more recent literature looking at direct comparisons between arthroscopic and open repair show clinical outcomes to be similar. Bishop in 2006 and Pearsall in 2007 did 2 head-to-head prospective studies looking at both arthroscopic and open repair. No in 2007 is a systematic review of the literature, again finding no significant differences between the 2 approaches. Purported benefits of arthroscopic repair include a better understanding of the tear pattern, easier ability to mobilize retracted tissue, and preservation of the anterior deltoid, which we know from some of the physical therapy studies is important in these patients with massive tears. So what about mini open repairs? So these are really previously the gold standard. You can get a transosseous suture repair, and there's no need for expensive implants. And I think in the days of healthcare reform and cost in medicine, this is an important consideration. But I'd like you to take a moment and think very specifically about massive tears. So is this really the best option for massive tears, or is doing a mini open like trying to build a ship in a bottle? Regardless of the approach, I think it's important to remember key principles in repairing rotator cuff tears. An anatomic repair, a tension-free repair. So this is bringing the cuff down with the arm in a neutral position. This isn't splinting patients in the abducted position to get the cuff to heal down to the tuberosity. Anatomic footprint restoration, secure fixation, and really creating an environment of healing, preparation of the tuberosity and giving the cuff the best ability to heal. Looking at different techniques available for repair. So there's a lot of literature looking at different anchors and anchor configurations for arthroscopic repair of rotator cuff tears. And I think the take-home points is, at least as we stand today, that there is no clinical significant difference between single row repairs, double row repairs, or transosseous equivalent repairs. However, I think it's important to consider that there's a large amount of biomechanical literature that argues the benefits of double row repair and transosseous equivalent repair. And I think the one point that's important to remember is the concept of load sharing. So a transosseous equivalent repair allows load sharing between all suture anchors. So a patient, as you see in the middle slide, undergoing external rotation, the posterior inferior suture anchor in a double row repair sees an increased amount of strain. In a transosseous equivalent repair, that strain is shared amongst all suture anchors. Other techniques for repair. So Burkhardt really popularized this concept of marginal convergence. And this is a side-to-side repair for massive tears. This really converts the U or L-shaped tears to a more manageable crescentic shaped tear. It allows the margin of the tear to converge towards the footprint, and either allows for anatomic tension-free fixation at that level or simply just a marginal convergence. This helps to minimize strain at the repair site. And you're seeing here in the video marginal convergence technique is the cuff was mobilized, now brought back down to the tuberosity. And now what we're dealing with is a smaller crescentic type tear, which we've all taken care of and know can bring out to the tuberosity in a tension-free environment. Other techniques for repair for massive tears include the concept of interval slides, again also popularized by Burkhardt. These allow repair of previously irreparable tears. Utilizes the anatomy with an anterior interval slide with release of the coracohumeral ligament and the rotator interval. Posterior interval slide, release of the interval between the supra and infraspinatus tendons. Again, popularized by Burkhardt in 2004. But the important thing to consider here is even the guy that described the technique uses this in only 10% of massive tears. His series shows some clinical improvements in patients, although they're just small numbers. So what about repairs that you can't, or massive tears that you can't repair? What about the concept of partial repair? And I think we take a few moments and do a brief biomechanical review and understanding the concept of a functional rotator cuff tear. Inman in 1944 described the concept of balancing of force couplers in the shoulder. He described the balance of the deltoid and the inferior cuff and helping to center the humeral head on the glenoid. Burkhardt expanded on that concept, describing balance in the axial plane, subscapularis in the infraspinatus, again helping to center the humeral head in the tuberosity. Burkhardt created the concept of a suspension bridge. So patients that have a tear of the supraspinatus tendon alone really can have a normal functional result. So that infraspinatus tendon, the insertion in the tuberosity, allows for normal shoulder mechanics. In tears that you can repair just part of the tendon, particularly the infraspinatus, patients do well. So Burkhardt had a series of patients showing 93% patient satisfaction. Duralde in 2005, 68% good to excellent results for partial repair of massive rotator cuff tears. Moser and Berth did head-to-head comparisons of partial repair versus debridement alone, showing improved clinical outcomes over debridement. So what about the truly irreparable cuff tear? Is debridement a reasonable option? I think it is. And Rockwood in 1995 showed 83% satisfaction results. Gartzman in 1997, 79% of patients were improved. Ellman in 1993, 86% significant relief of pain and satisfaction. However, I think debridement alone should be approached with cautious optimism. Kempf in 1999 described poor outcomes in younger patients. And again, the concept of the spectrum of rotator cuff disease. If you're not able to repair the cuff or restore a cuff to a functional tear, these patients probably continue to deteriorate over time. These poor results are observed more in a younger patient population. Levy in 1991 showed that these results deteriorate over time, 84% at 1 year, falling off to 68% at 4 years. And then Wiley in 1991 described that cases of anterior superior escape following subacromial decompression. So remembering the coracoacromial arch and the importance of that restraint in these massive cuff tears that are not able to be repaired. What about the biceps tendon? Is this a secondary pain generator in shoulders with massive rotator cuff tears? Chen in 2005 looked at 122 full-thickness rotator cuff tears and found that all massive tears were strongly associated with an advanced biceps lesion. Bilal in 2007 treated a series of massive rotator cuff tears with biceps tenotomy or tenodesis alone. 78% of patients were satisfied. Earlier article challenges that concept. Klinger in 2005, debridement with and without tenotomy, no difference in outcomes. So not necessarily hitting the ball out of the park here, but an important consideration in addressing patients that have these types of tears. So again, other options for irreparable tears. Salvage options include tendon transfers and biologic augmentation. Tendon transfers are really indicated for the younger patient who's not really ready to proceed down the arthroplasty road, patients with significant weakness and significant pain. The latissimus transfer has been described for posterior superior tears with reasonable results in the literature. Pectoralis transfer has been indicated for anterior superior tears, so restoring the subscapularis. Limited data for use in massive rotator cuff tears. Biologic augmentation is kind of a hot new topic in the literature. Numerous studies, but all with limited data supporting their routine use. The end stage of rotator cuff disease is probably rotator cuff arthropathy. And if we remember our shoulder biomechanics, loss of the force coupler, loss of that infraspinatus, helping to depress the humeral head into the glenoid, you begin to have active anterior superior migration of the femoral head, femoralization of the humeral head, acetabularization of the acromion, and eventual erosion of the coracoacromial arch and anterior superior scape. In these cases, the options for repair are really not there, and now we're looking at arthroplasty options. So what about total shoulder for patients with a massive rotator cuff tear? Mattson in 1998 described glenoid component failure in patients with rotator cuff deficiency, and this is the rocking horse phenomenon. And this is really back to the force coupler, so you've lost that centering of the humeral head on the glenoid, so you have asymmetric wear of these components. A very interesting study by Edwards in 2002 looked at patients undergoing total shoulder arthroplasty who were found at the time of surgery to have an incidental rotator cuff tear. Patients that had a supraspinatus tear alone had identical results to patients with an intact cuff. Patients that had involvement of the infraspinatus tendon began to have inferior results. What about hemiarthroplasty? A recent review of the literature is shown here, showing reasonable results. So 60 to 89% of patients were satisfied. Some improvements in range of motion, but not again, significant. 120 degrees, 100 degrees, 111 degrees. What about reverse total shoulder arthroplasty? So again, remembering the biomechanics of the shoulder. So increasing the deltoid lever arm allows increased strength in the deltoid, allows the deltoid to substitute for the absent cuff. The semi-constrained design of a reverse total shoulder arthroplasty prevents anterior superior scape. And clinical outcomes are encouraging, and particularly in patients that have true anterior superior scape can make a significant difference in their functional abilities. Complication rates are high, but if you look at the overall complication rates reported in the literature for reverse total shoulder arthroplasty, indications for cuff tear arthropathy have the lowest number of complications. I'd like to take a moment here and transition to the case discussion and the debate portion. We'll ask Dr. Wall and Dr. Smith to come up into their respective corners and review hopefully some of the controversial aspects of rotator cuff tear. It's our first case. 72-year-old right-hand dominant male with acute onset of shoulder pain and dysfunction 2 weeks ago. Tripped over a parking block at church and landed directly on his right shoulder. Immediate pain, decreased function. Saw his primary care physician, normal radiographs, told to give it some time. He's gotten better since, sleeps well, minimal pain during the day, but is not able to actively raise his right arm. The physical exam, normal painless passive range of motion, but active elevation only to 25 degrees, and significant weakness in his supra and infraspinatus tendons. This shows a massive tear of the rotator cuff. Here looking at this image shows the rotator cuff muscle belly and the end of the tendon insertion. This tendon belongs all the way over here on the end of the tuberosity. It's retracted back past the center of the humeral head, almost to the level of the glenoid. And here on the other view shows complete absence of the cuff all the way across the top of the tuberosity, where you normally see a dark colored tendon structure inserting on the tuberosity at this level. So I'm going to ask you guys what you think. We're going to switch back over to the audience response system and give you guys a chance to say how you'd like to treat this patient. Should we do nothing? Physical therapy? Corticosteroid injections? Should we attempt a repair of the cuff? Is this a guy that we're not going to be able to bring his cuff back? Should we think about concepts of partial repair? What about debridement or a subacromial decompression? Or is he on the way towards an arthroplasty? So most people want to repair this cuff. Dr. Wall, what do you think about this case?
I think this is one of the places where we have a real hole or a real difficult issue with our treatment paradigms. This is a gentleman who doesn't have pain. It's always easy when someone's got weakness. 3 out of 5, the guy can barely get his arm up against gravity or only to gravity, but no pain. And that's tough. The guy's able to sleep. There are some concerning things. His age, again, he's in the 70s, 72. So age, as people get beyond 60, can be a poor prognosticator for repairs. I think the problem, if you go to the MRI, is that he has or is just about to burn a bridge here, in my opinion. If you look at where the rotator cuff is sitting, it's at the equator or just beyond the equator of the humeral head. And so the problem for this gentleman, although he's not painful now, is that if he comes back to your office in 6 weeks and he's painful, or 12 weeks, and that rotator cuff has retracted any more medially over the glenoid, he may no longer have a repairable tear. He may have a tear which can no longer be repaired. So I think this is a case where you speak at length with the gentleman and explain to him the different options that he has. One option would certainly be to arthroscopically evaluate the cuff, and if it does seem to be repairable, to consider arthroscopic repair, if anything, to try and preserve the length of time before he becomes symptomatic or he develops a high-riding humerus or an irreparable tear, because then I think you're in a place where he doesn't have as many options immediately.
Thoughts, Dr. Smith?
I agree with everything that's been said. I think there's a challenging dilemma there, but I will also add then, this to me is a 72-year-old guy. It's his dominant arm. He's fairly active. The head's not high riding. He has no atrophy. It sounds like this is an acute tear. Well, we could argue that he may have had some partial tearing and things. It sounds like this is a guy who could raise his arm normally the day before, and now he can't raise his arm, and this is an acute situation. My bias would be that I kind of think we ought to maybe repair that, but that's my bias. And so I agree with what Dr. Wall just said, that I think we do need to kind of let the patient know about all the pros and cons and the risks and benefits and what they're up to afterwards as far as rehab, and let them kind of decide what's best for them. To not push my bias that, hey, you're a 72-year-old guy, it's your dominant arm, and this is an acute tear, and you're going to be better off functionally if we fix this, to not extrapolate that to him and push him towards surgery, because it's not a life-threatening problem. It's kind of up to him if he's up to all the issues and challenges ahead.
So again, the concept that we talked about before, we're treating patients, not rotator cuff tears, and this particular patient chose not to have surgery. So he's 8 months out now. No pain, sleeping well, near normal function in ADLs, has mild weakness in external rotation, forward elevation and abduction, and painless subacromial roughness.
He's actually a patient of mine, and the way I treated it, and so I'm thinking the same thing that Dr. Wall was thinking about. I don't want this to become irreparable, and so I made him come back every 2 weeks for about a month and a half, just kind of, again, not pushing him to have surgery, but making sure that he understands that we may burn a bridge here, and if you're doing okay, great, good for you, but if not, and in the end, he's really happy with his choice, and so so far so good. Maybe he'll get cuff tear arthropathy, I don't know, but this is what he wanted to do.
So our second case, 51-year-old right-hand dominant female with a long-standing history of right shoulder pain and weakness following a fall 7 years ago. This case becomes a little bit more challenging because she had a previous 4-quarter amputation of her left upper extremity for recurrent soft tissue sarcoma previously. So this is her only dominant arm that she uses for all activities of daily living. She has significant pain, some weakness with overhead activities that's been slowly progressive over the last few years. Reasonable motion. Weakness with scaption and external rotation, full strength of her subscap. And I apologize, I don't have her MRI images, but the MRI showed a massive rotator cuff tear with retraction beyond the equator of the humeral head, almost to the level of the glenoid, very similar to the MRI that we just looked at. She had a high riding humeral head with noted intact articular surfaces, but some early acetabularization of the acromion and significant AC joint arthritis. So here are the arthroscopic images of this patient during her arthroscopy, showing the humeral head here, some early arthritic changes on the top of the humeral head, the surface of the glenoid and the cartilage surface there, and here's our rotator cuff, tendon retracted back almost to the level of the glenoid, involving in entirety the supraspinatus, and then coming back part of the infraspinatus here, better seen on this second image. And then we'll ask you guys again how you'd like to treat this. This is a patient that we can think about a rotator cuff repair. Significant pain but no weakness. Is this a significant massive tear that we're not going to be able to repair? Consider a concept of partial repair, debridement decompression, or are we looking at more arthroplasty options? So Dr. Wall, do you want to comment on this case? This patient underwent an arthroscopic repair. It was a year out from surgery. Very happy with her outcome.
Yeah, this was a patient of mine. She'd been sent down from Alaska. And I think this is again, a tougher case, a little different than the first case because the gal is so much younger, at 51 years of age, and having only one extremity. Here you really have to think, she'd been sent down because she'd been told by a few surgeons that there was nothing that could be done for a rotator cuff tear. But an easier decision in some ways because she had pain and weakness and it was the only arm that she had. And we discussed that it's quite possible that the tear would be irreparable. And I think this is, for me, one of the advantages to arthroscopy is you can sort of make the decision about whether or not a tear is irreparable based on whether or not you can repair it. So you sort of make a game time decision in a case like this. And in her case, we were able to do a margin convergence and convert this pretty massive tear into a smaller crescentic variant and then fix it. Even so, you can see the quality of tissue there and things is not as robust as you'd like to see, but we were pretty happy with the repair. And I'll tell you though, it's another case where you sort of have to lay crepe and explain to her, it's certainly a case that makes you nervous when you're operating on someone's only arm and it's their dominant arm and dealing with a massive tear situation. The plus side of this being that if you can get the tear repaired, you look good because she's now got a rotator cuff. If you can't, really she's not worse off outside of the pain and disability and time it takes to try and rehab someone from not trying. If you don't repair a cuff, she has a rotator cuff tear. If you repair and it doesn't do well, she has a rotator cuff tear. So these cases, I think, are challenging, but that sort of was the thought that went into it on my part here.
We mentioned at the beginning of the first case that it's a challenging situation, 72, et cetera, et cetera. This one's quite a bit more challenging. It's her one good arm. And so take a deep breath before proceeding here. That being said, I think everything is reasonable here. It's all fine. The reason I say that is to say it's okay to give it a shot, but she needs to know really clearly the pros and cons and the things going on here. This is your one good arm. It doesn't look repairable, but we can go take a look-see. We can see if we can mobilize things. We can see if we have decent enough tissue to put stitches in that's going to pull like shoe leather rather than wet Kleenex. And then if it's okay, like it is, repair it. But this isn't a case where I would lay some crepe. This is where I'd lay a lot. In general, the first thing I'm going to say to her is, I know you have a big rotator cuff tear. I know you have some pain, but I'm very impressed with your function. She can raise her arm above her head. She's got some reasonable strength. This isn't a pseudoparalysis, horrible disability. And so this is a situation where this patient will drag me to the operating room rather than the opposite is the easiest way for me to put it.
In repairing these massive rotator cuff tears, both open and arthroscopically, what are some of the techniques you guys use for obtaining a tension-free repair?
Actually, I don't know that the techniques are terribly different. Steve Burkhart calls it the interval slide. We've always done cutting the coracohumeral ligament, cutting the rotator interval, trying to debride back to good tissue, scar tissue above, releasing the capsule above the superior labrum and the biceps. There are a number of ways to mobilize a rotator cuff, and they're really very similar arthroscopically or open to my eye. Chris?
I think if you're a skilled surgeon with an open approach, you can do some of the things that arthroscopic surgeon can do arthroscopically. I'm not as good at doing it open as I am arthroscopically, and I think the take-home message here is you do what you feel like you can do well. I think the concern here with many people who do mini open repairs is that they're not going to take the time to try and put the tissues together in an appropriate way. What they're going to try and do is release the tissues medially and then just try and pull the cuff out and tack it down to a Hail Mary and close the skin and hope they do okay. I think the advantage for me using an arthroscope compared to open procedures is when and this is probably more a testament to my lack of skill with an open procedure more than anything else, is just I feel like I am working through a bottleneck to try and do this kind of a repair through a small incision versus if I'm using the arthroscope, as you can see from the pictures, it's as if I'm standing inside the shoulder working on it. But I certainly don't advocate that everyone try and approach these in the same way. I don't think that's necessarily the take-home message. It was interesting. I spent some time in Switzerland when I was doing a fellowship and worked with a pretty famous shoulder surgeon there named Christian Gerber. And his approach to rotator cuff tears was interesting to me in that he did either fully open repairs, taking the deltoid muscle completely off and exposing the cuff so he could put the cuff together anatomically, or he did arthroscopic repairs where he was basically inside the shoulder working on it, but felt that the mini open repair was kind of the tool of the devil, that you've lost either advantage by trying to work through a bottleneck. But I think, again, it has to do with the skill level of the individual and their comfort with what they're doing, and it's not easily globalized from surgeon to surgeon.
And briefly, if you look back at her MRI report and even her arthroscopy pictures, she has some early arthritis on her humeral head and her glenoid. Does that change your thoughts on thinking about a repair versus debridement or arthroplasty options?
Again, going back to what I was mentioning originally, it doesn't mean I would or wouldn't do anything, but it's just another one of those bad prognostic indicators. The head's already bumping on the acromion a little bit. The head's riding a little high. It's showing in a way that it wants to be there, and it's increasing. It's extremely difficult to change that mindset, if you will.
Case number 3, 59-year-old male, pedestrian versus car 3 months ago, sustained multiple injuries, mesenteric laceration, splenic laceration, pelvic ring injury, a multiligamentous knee injury, and a right shoulder injury. So he now comes to clinic for follow-up of his shoulder injury, has pain and significant limitations in the function of his shoulder. So his physical exam, really significant deficits in active motion and significant weakness with both scaption and external rotation, only 3 of 5 strength. Here again, an MRI of his shoulder showing a massive rotator cuff tear. So here, tendon edge retracted back to the center level of the humeral head. No insertion seen here on the tuberosity, and again on the other view showing, again, no tendon coming across. Pictures during his arthroscopy. What do you guys think about treatment options for this case? Most people looking at a repair. So this tear was felt to be irreparable during diagnostic arthroscopy, so the patient underwent a debridement and biceps tenodesis. Dr. Wall, your thoughts on this case?
Well, this is one of my cases, so this is a situation similar to our gal who had just the single dominant arm. Unfortunately, this is again a youngish fella whose vocation requires him to work overhead. Again, this is sort of the intraoperative decision-making, seeing in this gentleman that his cuff tissue, if you looked at that video, couldn't possibly be mobilized or even sort of brought together for any kind of a semblance of repair. It had retracted actually medial to the glenoid. It was would have been like sewing snot to moonbeams to try and to fix this. And the problem here, I think, for me, this case, and I'd love to hear Kevin's thoughts on this represents kind of a hole in our treatment paradigm. If you look carefully, this guy really hasn't developed arthritis yet. I'm not sure that he's a candidate for a delta prosthesis or a hemiarthroplasty. We don't have great biologic solutions in terms of the patches and some of the other things that have been sort of brought forward as potential ways of dealing with these massive cuff tears to try and augment the tissue. Those things haven't really panned out in the literature. So we've got a guy who's really pseudo-paralytic in his arm. He doesn't have a rotator cuff tear. He doesn't have a rotator cuff, excuse me. He has an overhead vocation where he requires some strength. And I'm I'm a bit at a loss at this point of what to do except for debride the tear and try and rehabilitate him as best we can.
I think for you young people in the group, please, as you proceed into practice, get used to saying the word no. The reason I say that is that there are things we can't fix and make better, and you need to understand that. And it may be patient factors, it may be surgical factors, it may be that they've already got a 98% shoulder, and your window of opportunity is so small that you need to. Harry Callahan was Dirty Harry, and a famous quote of his is, "A man's got to know his limitations." That being said, I would have done the exact same thing here. The reason I say that is to say this is a young person with a reasonably acute tear, that with horrible function and things, and so again, I'm not going to tie him down and make him have surgery, but I'm going to maybe push a little harder that maybe we can get a partial repair. Maybe we can get a little bit of the force couple back. Maybe we can get you some function of your shoulder. And so I'd love to try. And so I think really, in all honesty, I think the neatest point of this case compared to the 51-year-old lady is that I probably would have laid a lot of crepe with the 51-year-old lady because that's more of a chronic situation. There are some bad prognostic indicators of a little high riding head, et cetera, et cetera. This one doesn't have quite so many. So I might have raved a little bit more about my ability to repair this one than that one. But indeed, it's exactly the opposite. So the take-home story, I never tell my patients, I guarantee you I'll repair your rotator cuff, because I don't know until I put some stitches in it, and I pull on it, and that I can mobilize it, and that it's not wet Kleenex. And so the take-home message is, I would have actually guessed the repairability was the opposite of the two, but therefore, don't guarantee your patients, because then they're really bummed when you come out and tell them that you said you could repair it, and so now what am I going to do? One could argue this is actually the kind of guy that might be a tendon transfer candidate, and it depends on his situation. So that is something I would explore with him, but he needs to understand that this is a big thing. It doesn't make his shoulder normal, and maybe we can get him to shoulder level with a lat transfer or something like that. But long run, perhaps for a short slide. But that's a great point, and this is the kind of guy. I'm not a huge tendon transfer fan.
No.
I think there's a very small number of people that might be reasonable. This is the kind of guy that we might buy time, prevent his arthropathy ever or delay it until other options are available or better surgeons come along.
Kevin, you do more arthroplasty and prosthetic work than I do. Do you think that doing a tendon transfer in any way burns a bridge for further delta or other prostheses? I know Pascal Boileau and some other surgeons say that it's actually almost indicated before you do a delta prosthesis, but what's your sense on that?
Well, I don't think it's indicated. The reason I say that is to say, to me, it's a very small group of patients who it's reasonable to even consider it in, but I don't think it burns bridges. A delta, a reverse shoulder, is still very much a salvage procedure for me. It's kind of, we've tried and we've thought of everything else we can think of, and so now let's move on to the big bad reverse. But I don't think I'd ever push anybody to say that you got to do a tendon transfer before you ever do a reverse, because that's putting a lot of pressure on people to do something that maybe, you talk about a long run for a short slide, it may be futile in many of the patients I see.
Yeah, just some follow-up on this gentleman. You know, he's not particularly happy with his shoulder function. We had discussed tendon transfers. As you probably saw from the history slide, he'd been through a lot. This is a multi-polytrauma victim. He'd had multiple surgeries for his abdominal and knee injuries and things like that. And I think he's taking a short hiatus from surgery for a while, which I certainly can't blame him for. But that's certainly an option if the shoulder becomes his sort of primary problem, I think, to go down that road.
Dr. O'Kane?
It sounds like in a lot of these situations, you may not really know what you can accomplish with your repair until you actually get in there and take a look at it. And if that's the case, just in terms of this debate, it seems to me then it would make more sense to at least approach that kind of a patient potentially arthroscopically so that you can see what you're able to do. And then whether or not you would go open to try to get your best repair, you could decide based on your surgical expertise. But, and correct me if I'm wrong, if you're going to approach this purely open, how are you going to make that initial assessment without starting off on a fairly significant surgery, whether or not you are able to pull these pieces together and create some kind of a repair?
I might be the best person to answer this because I'm the dinosaur here. I still fix my rotator cuff repair or rotator cuff tears open. That being said, that's a great question. The reason I say that is to say I'm a dinosaur, but I got a few new age things going, and so I do think that the best way to approach this is arthroscopically to release everything I can, free up everything, put a clamp on the tendon, pull on it. Can I mobilize it? Is it good tissue? Is it pulling apart as I pull on it, et cetera, rather than going open. That being said, I learned the open, smooth, and move, and I think that's fine too. We could argue about the relative invasiveness of one versus the other, but we did those with the rotator cuff on, through a deltoid split. We didn't violate the rotator. I actually would argue that I can see the rotator cuff just fine, even massive tears to repair through an open incision. And sometimes I extend back and I make another split in the deltoid through the middle and posterior bundles. Sometimes I'll extend down to get the subscapular tenodeus, the biceps, and do a low axillary delta pectoral kind of a thing. So I can get to it. The incision just gets a little bit bigger, but I can get to it. But again, I do think for patients in their best interest, the best way for me to find out. And so what I do then is I tell them, let's look arthroscopically first, let's clean everything up, let's release, et cetera, and then let's see if the rotator cuff's repairable. And if it is, I'm going to open it and tack it down in the best way that I can. Again, you've heard an older guy around here talk about the surgeon being the method, and that's the method that works for me.
So kind of the follow-up to that case, here's a patient that had a debridement. So 63-year-old right-hand dominant female with insidious onset of right shoulder pain 4 years ago, underwent surgery, had an attempted repair, was an irreparable tear, so just had a debridement. And now over time, she's progressed to have functional limitations and pain. And her functional limitations are significant. Active elevation to 15 degrees. And here's her radiographs. On these images here, we begin to see the telltale signs of rotator cuff arthropathy, femoralization of the humeral head, and acetabularization of the acromion. So you can begin to see the acromion becomes in a hooked form of a morphology as the head sits up and begins to articulate with the undersurface of the acromion. On the lateral view, you can see the humeral head here and the glenoid here, and are beginning to see some posterior erosion of the glenoid here, where this joint space is much more narrow than it is anteriorly. Treatment options are similar. We'll kind of jump ahead here. So this is a patient that had a reverse total shoulder. Dr. Smith, what are your thoughts here?
Well, this is my case, so I happen to have a few thoughts. That being said, actually, I think one thing you should know is I actually put this gal off for a year. She was sent to me to have a reverse, but she still had 70 degrees of active elevation. She had pain, but you also noticed in her medical history, she's a complicated gal. She's not the one that anybody should jump to go take to the operating room. But she progressed over that time, increasing pain. Now her active elevation is only 15 degrees. She's up underneath the acromion, et cetera, et cetera. And in that situation, I actually am not a huge reverse total shoulder guy. I probably do a half dozen or a year at the most. But this is the situation. To me, there are three main situations. To me, it's still mostly a salvage thing. But cuff tear arthropathy with pseudoparalysis that they can't raise their arm, I can improve that. A failed hemiarthroplasty with tuberosities off and again, no function. And then the final thing is anterosuperior escape. Those are, if I have three main indications, that's it. And so for me, this was a reasonable thing to consider. She's happy. She's 15 months out. The reason I know how she's doing at 15 months is she came back because she's in a little bit more pain over the last few months. And so I just saw her a month ago, and we're just trying some time and tincture of time and seeing how things go. But she's got a little settling of her glenoid, her glenosphere into the remaining glenoid, and so we'll see. Nothing we do is benign, and unfortunately, nothing we do has a lifetime guarantee.
Well, we wrap up with one more case here. Great motion, some weakness. Her films. On this image here, we again see signs of rotator cuff arthropathy, superior migration of the humeral head, and almost in this case, almost a wisp of acromion, so significant bony loss in the acetabularization of this shoulder. And on both sides, you see some early osteophytes forming on the inferior aspect of the humeral head, and also seen here. And again, humeral head articulating with the acromion, significant rotator cuff arthropathy. So in this case, are we also thinking about a reverse total shoulder? What about a total shoulder or a hemiarthroplasty options? She went on to have bilateral hemiarthroplasties with the CTA head. Excellent function in ADLs, mild weakness, smooth passive range of motion, and happy with her outcome. Dr. Smith, thoughts on here? Why a hemiarthroplasty and not a reverse here?
I kind of alluded to him when we were talking about the reverse. So again, this is my patient. Most people wouldn't do this arthroscopically, I bet. And so that being said, this is a gal who actually had reasonable function. She could raise her arms above her head, even with those horrible x-rays you saw with an acromion that's like a wafer. So she had some reasonable function. She still had maybe enough of a force couple or enough deltoid strength or what we could argue the reasons why, but same exact MRI, same exact x-ray, one person can raise their arm and another person can't, go figure. That being said, she could. And so I think in that case, this was an operation then more for pain than function. And given the right motivated patient, et cetera, if I can just smooth that head, she's comfortable, she gets a better night's sleep and can still raise her arm, because if I cannot disrupt the biomechanics of her musculature, this is what we hope comes out. Now, you know, we all take pictures of our best patients for our lectures that we give, but still, she's a great result. She even, to the point that she had that same operation and came back 2 years later to have the other side done. And so every decision, there's a little dilemma what we should do, because some people will do a reverse in this situation, I guarantee you. Some people just do a smooth and move. Who knows? But in this case, this is what we did here, and she's happy.
So Kevin and Chris, you know, the one interesting thing that you pointed out is that people with identical imaging MRs and X-rays can have dramatically different functional capacity when they have rotator cuff arthropathy. Is there ever the possibility with conservative treatment, aggressive rehab, to turn that patient from the last slide into the patient in this case? So somebody that presents with a massive cuff tear, but they're decompensated, they have pseudoparalysis. Is there any way to take them and turn them into somebody that has enough functional capacity to do a CTA head as opposed to the more complicated, risky delta procedure?
So it's a great question, Howard, and as an extrapolation from that, it's also interesting that people with the smallest partial thickness tear can be absolutely miserable, and yet some massive, huge tears have no pain whatsoever. Again, go figure, but I don't know that we completely understand the mechanisms of pain, et cetera, et cetera. I just want to show this gal first, because I'm a huge fan of non-operative treatment. So this is an 85-year-old gal, very briefly, 85 years old, comes in with an acute episode, et cetera, et cetera. It's her non-dominant arm, and her head's a little high riding. She can't really raise her arm, but she's gotten a little bit better in the last 2.5 weeks. Just a real character, a real nice lady, 85, head's a little high. You can see just a little wear on the undersurface of the acromion, a little wear on the greater tuberosity. But I treated her non-operatively. Here, this is a CT arthrogram because she has a pacemaker. She can't have an MRI. But you see that the head's right up underneath the acromion already. This is an acute on chronic situation probably. She had some stuff going on before she hurt herself 2 weeks ago. And she's 85, and it's her non-dominant arm, et cetera, et cetera. And so I treated her non-operatively. And so this is her 6 months out. Interestingly, her right shoulder, so we treated her left shoulder, but her right shoulder had a rotator cuff repair, distal clavicle excision, and subacromial decompression 4 years ago. And so now she uses her left arm. When I said raise both arms up for the picture, she goes like this. And so she uses her recently torn rotator cuff arm after just a couple months of time calming down, et cetera, to raise her previously operated shoulder. And so At 85, non-dominant arm, et cetera, et cetera. I just am a big fan of non-operative treatment, and this is a great example of why we might consider that. Now, if you're 59 and you fall off of a roof and can't raise your arm, I'm going to probably push to fix that week if we can. Does that make sense? Does that answer your question?
Pretty much. So, yeah, Chris.
I would say that, you know, this is where it's helpful to have a lot of different things in your armamentarium. If you look at the last case that we presented, she effectively had a CTA prosthesis. It was just her own head. I mean, she had a great fit between the top of her head and her acromion and relatively little function. So go to the CT arthrogram of the last lady that we're talking about. So again, this is a lady who's kind of done an auto CTA. She's got a nice round head. It fits very nicely under her acromial arch. In the sagittal views there, you can see it's almost a perfect fit to the right. If you go back one step to the gal before, or two before, where the delta prosthesis was, now that girl had a lot of posterior erosion of the glenoid, right? So if you put a hemi in her, you're also going to be sort of obligated to either do a prosthetic resurfacing of the glenoid to try and keep the head centered in the glenoid or not. Because if you look at this case and look at the version of the glenoid here, you've got this significant retroversion or posterior erosion of the glenoid there. I think putting a hemi in that person is going to be challenging, and maybe even pushed Kevin's idea about doing a delta in her. And then the last case, the gal probably had more normal glenoid version, and she's a case where a hemi, I think, is a good option. So having few different tools in the toolbox, I think, is pretty helpful in those cases.
Can I answer your question?
Yeah, thank you.
Should we move away?